Hello all, and welcome to another session of vertical integration classes specifically designed for UG students. And today we will be discussing on the topic lymphadenopathy. For the same, we have a very eminent panel of panelists. So I'll be introducing them to you first. Dr. George sir, who is a professor in the Department of General Surgery. Dr. Intu madam, professor from the Department of Pathology. Dr. Akshara, associate professor from the Department of Anatomy, and Dr. Kiran, assistant professor from the Department of General Medicine. So we'll be following the same pattern which we have been always following, that is the pre-planned questions, and then we will end with most commonly asked questions from this topic. To start with, I will start with Dr. Akshara. Ma'am, can you describe the structure of lymph node and explain the functional significance of each component?
Okay. So firstly, that's starting with the structure of the lymph node. So lymph node is as it actually acts as a filter, and it is a secondary lymphoid organ that is seen along the lymphatic vessels. So this lymph node is a filter system, and it is phagocytoses the antigen bacteria as well as give the immune response antibodies to the circulation. So the afferent lymphatic vessels that is reaching this lymph node. So lymph node is kidney shape structure or bean shaped structure, and it has a convexity. So to the peripheral convexity, the afferent channels, lymphatic channels, will take the lymph to the lymph node, and this will filter in the lymph node, and through the efferent channel it is passing out. The filtered lymph node is passing out. So it is covered by a capsule. As I mentioned, it is a lymphoid organ. So lymphoid organs will have the collection of lymphocytes, and lymphocytes are responsible for the immune response, integral part of our immune system. So this is a collection of lymphocytes. We can see it is encapsulated. A capsule is there, and it is encapsulated, which is where the capsule is there, and to this capsule the penetration of this afferent ductule or afferent lymphatic channel will happen. And within that, it is entering into the interior of the lymph node, and the lymph node can divide into two areas, that is cortex and medulla arrangement can be seen. So in the cortex part, we can see the collection of the lymphocyte, and the collection of lymphocyte is called as the lymphatic nodules. So in the cortex, we are getting the lymphatic nodule, and this lymphatic nodule structure of each lymphatic nodule is that peripherally we can see small lymphocytes, they are closely packed and heavily stained, and the central portion of that we can see the pale stained area, that is called as germinal center. And that is also, if it is not presented to antigens, it will be fully collection of the small lymphocyte, and if it is presented to, then it is called as primary lymphatic nodule. But when it is interaction with this antigen happen, then the central portion is called as germinal center. So what we can see in the germinal center is actually the lymphoblast we can see, and that is lightly stained with less chromatin. We can see the differentiation of the chromatin is different in the different lymphocyte. So they are large, they are lightly stained, and this lymphoblast will give rise to the next lymphoblast, and this lymphoblast is giving rise to the lymphocyte. And this lymphocyte, again, it is condensed with the keratin and come to the periphery of the lymphatic nodule with darkly stained. This is the structure of the cortex of your lymphatic nodule, cortex of the lymph node. Then we are moving, so B lymphocyte, we are getting actively there. B lymphocyte, and terminal center is the active site of this lymphocyte protection in the case of lymph node. Then in between that we can see that's capsule, which is entering into the cortex, and that is known as trabeculae. So it is continuous the trabeculae, and on either side of trabeculae we are getting the trabecular sinus. Under the capsule we are getting the subcapsular sinus. So then it is reaching to the medulla part. So paracortex is there. That's a transition between the cortex and the medulla. And paracortex will consist of the T lymphocyte as well as B lymphocyte is there. And there is cortex medulla region. Medulla region is actually light stained area where there you can see the medullary cord, and the medullary cord we are seeing plasma cell, macrophages, reticular fibers, and then there is medullary sinus, capillary lined area called medullary sinus is there. So what you're seeing is the efferent lymph that is passing from this efferent channel is getting to the subcapsular sinus, and subcapsular sinus, then it is drained to the trabecular sinus. Filtering is happening there, and this trabecular sinus from this lymph is passing to the medullary sinus, and from the medullary sinus this filtered lymph is entering into this efferent ductule. So there is antigen activation. When it's exposed to this activation happen, our immune plasma cells are produced. B lymphocyte will differentiate to this plasma cell, so the antibodies are produced. That also will enter to this channel, and this is how it is entering to the bloodstream. So these are the function of the different areas of the lymph node.
Okay, ma'am. One more question to you. I know it could be a very large answer, but if you can keep it brief. What are the major lymph node groups in the body, and what is the usual clinical relevance to it?
So the major lymph node groups, like cervical lymph node is very important. There are different groups of cervical lymph node, like superficial group as well as deep group of lymph nodes are there. Superficial groups include the parotid lymph node that is related to your parotid gland and draining the temporal region and the lateral part of your cheek and all. And like that, we have buccal nodes on the buccinator. We can see like angle of the mandible. There is another group of mandibular lymph nodes are there, and they have the superficial groups which can be like superficial cervical nodes, lateral one related to the external jugular vein,
right,
and anterior group of superficial node related to the anterior, that is anterior jugular vein, which drain the below the hyoid bone, the anterior part of the neck. They are coming under the superficial group of the cervical lymph node.
Right.
And we have deep group of cervical lymph nodes are there, like jugulo-digastric node, that is related to internal jugular vein, upper lateral group, middle lateral group, and that upper lateral group, the most important one is jugulo-digastric node, which drain your tonsil.
Yeah.
Like that, the lower lateral group, most important one is jugulo-omohyoid node, and that drain the tongue. So these are about the deep group, and deepest groups like pretracheal, paratracheal, and this prelaryngeal node, which drain the trachea, which drain the lower part of your isthmus of the thyroid gland, your larynx, your auditory tube. All these are drained by the deepest group of the lymph node. So these are the cervical lymph node. And coming to the axilla, or coming to the trunk region, the most important one are axillary group of lymph node, as we are concerned with the lymphatic drainage of the mammary gland or the carcinoma. These groups are very, very important to consider. So we have the anterior group of axillary lymph node in relation to the lateral thoracic artery, as well as subscapular vessel. Posterior group is there. So among this anterior group of axillary lymph node is very important, because most of the breast is 75% is draining to the anterior group of the axillary lymph node, and posterior group is there. And then we have the apical central group. Central group is draining your upper limb mainly. So these group lymph node and their enlargement, or anterior group related to axillary tail of our mammary gland. So it can be mistaken for the enlarged lymph node. So these groups are important. And central group intercostal brachial nerve, so enlargement can compress this nerve. So these are important axillary lymph nodes. Coming to the mediastinum, we have the mediastinal lymph nodes, which drain the lungs and the mediastinal areas. So they are the other group we can see in our body. And coming to the abdomen, in relation to the aorta, we have the pre-aortic groups, that is iliac, superior mesenteric, inferior mesenteric nodes are there. And on either side of the aorta, we are having the lateral groups are there, para-aortic group. And so it will drain the structures that is supplied by the lateral branches as well as dorsal branches of aorta, like kidney or testicular, the testis, ovary. So these are the para-aortic nodes of lymph node. Coming to the pelvic region, again we have common iliac node, external iliac node, internal iliac node. So internal iliac, these nodes are concerned with the gluteal region as well as the pelvic viscera. They are drained by these structures. And then we have the inguinal group, which can divide into superficial inguinal and the deep inguinal group. They are also draining the external genitalia, the perineum, as well as the lower limb. So these are some of the important lymph nodes in our body.
Thank you, ma'am. Now, since we have already got an overview of the normal things, to Indu madam, madam, what are the microscopic changes which we usually observe in lymphadenopathy?
Yes, as madam described, the node has three main components. The B component, that is represented by the lymphoid follicles, the T component, which includes the paracortical area, and the sinuses in the medulla. So according to the antigen which is entering the lymph node, the way the different types of the cells react. So B cells, as we know, mostly react to, you can have an acute lymphadenitis or a chronic lymphadenitis depending upon the type of the antigen. B lymphoid hyperplasia, in that we see the follicles will be, as madam mentioned, when it is exposed to the antigen, will show the germinal centers, which become the secondary follicles. So there we have the B cell proliferation, which occurs in chronic infections and any other chronic antigen stimulation. The T area that is represented by the paracortical area, that will be hyperplastic whenever you have antigens which are tackled by the T cells, like any viral infection or any autoimmune disorders. Autoimmune actually can show both B and T hyperplasia. So that you call it as hyperplasia because the proliferation of cells are happening, but they are non-neoplastic. So there will be enlargement of that compartment. And finally, you have the sinus histiocytosis, where you have very large antigens which cannot be tackled by the B or the T cells, like any parasites, or if you have any foreign, cancer cells or any foreign bodies entering, or tattoo pigment, all those will be taken up by the sinus, the histiocytes within the sinuses, because they can only handle that. And also you can have, there is no compartmentalization as such, you can have the entire lymph node reacting to an antigen, that is called a lymph node hyperplasia.
Okay, ma'am. Next to Dr. Kiran. Kiran, from a general medicine perspective or your practice, what are the common causes of lymphadenopathy you see? And from history, is there any way of kind of distinguishing between them?
Lymphadenopathy is a very common complaint that patients come to us in general practice, and differentiating them is actually quite complex because the clinical spectrum is large. From proper history and examination, we would usually like to place them in their different categories. The usual categories, out of which the major ones are infections. That is what we usually see in our practice. Second would be autoimmune. Then would be malignancies with lymphoproliferative disorders, and certain medications are also common causes for lymphadenopathy. Out of infections, again, it can be subdivided into bacterial, viral, fungal, out of which the most common bacterial infection that we can see can again be divided into localized and generalized. Localized infections are usually caused by cat scratch disease, streptococcal pharyngitis, Lyme's disease, etc. While generalized lymphadenopathy can be seen in syphilis, brucellosis, etc. Another major bulk of lymphadenopathy in India is secondary to tubercular. One of the most, the first differential, I think, if a patient would come with an unresolved fever, weight loss, cough, etc., would be to rule out tuberculosis. Viral infections are also very notorious for causing lymphadenopathy, out of which HIV also, one of the major symptoms of HIV in the first few years in clinical latency is asymptomatic generalized lymphadenopathy. Another very common viral disease that usually comes to OPD is infectious mononucleosis caused by EBV. They also present you with upper respiratory tract infection like features and lymphadenopathy. And other viruses like CMV, HSV, HHV, etc. are also very notorious. And also your MMR, your mumps, measles, rubella, etc. All your viral diseases will usually cause lymphadenopathy. Then you have protozoans like your toxoplasma and leishmania also are very notorious for causing lymphadenopathy. So a proper history is actually required with examination, because your route of investigations and your treatment will also be depending on your differential diagnosis.
Yes, sir. So that was about what you usually see in general medicine practice. Is the kind of cases you see different from that? And also some investigation like FNAC and biopsy is usually recommended. So when do you choose which and when?
That's a very good question. As far as lymphadenopathy is concerned, the clinical patients who usually come with a swelling in either part of the body, either it will be, as Madam had described, in any of the lymphatic drainage areas. It might be the cervical region or the axilla, or for that matter the abdomen, or in the inguinal region. So when you when you look at the cause, usually majority of the patients who come with to surgical departments are because either there's an infection which is undiagnosed and there is a intervention which is required to get the node, or there's a disease which is deep situated inside which will require a surgical intervention which is quite complex and where you cannot diagnose with a needle biopsy or FNAC for that matter. So considering the fact that the accessibility of the node, the presence of the node in an area where you have a surgical intervention required, such diseases come to general surgery department so that we can get the node out and send it for histopathology where further studies can be found to diagnose the disease. Having said that, there are other areas where you have to do intervention, especially diagnosed cases, as a part of the surgical cure of that patient, especially metastatic diseases in draining areas or primary draining organs. If you have a carcinoma thyroid with papillary carcinoma, or for that matter any other differentiated thyroid carcinomas where you have lymphatic metastasis, you'll have to do a neck dissection also along with that. If there is a drainage from the breast cancer which is draining to the axillary lymph node, you'll have to go for dissection either for a sampling or axillary dissection, or for that matter any lymphatic drainage area in the abdomen or in the groin region causing lymphatic metastasis to the inguinal nodes. You'll have to go for ilioinguinal block dissection. Depending on the metastatic potential and the metastatic stage of the tumor where it has gone to the lymph nodes, we'll have to dissect out the lymph nodal group for a complete cure of that disease, provided it can be either proven by an FNAC or by a biopsy. So that is another indication.
Indu ma'am. So what are the common diagnostic techniques which are used on a lymph node pathology, and what information do they provide?
Yeah, we have, as mentioned, we can do an FNAC, an aspirate from the node, and that gives an early diagnosis, maybe within 4 hours or 5 hours, or even on-site evaluation can be done with an FNAC. The cells are spread on the slide, the aspirated cells are spread on the slide, and if it's a frank malignancy or an infection like tuberculosis, you can make an early diagnosis. And then in addition, the same tissue or a different tissue can be sent for a histopathological examination after fixation in formalin. In that we see the slides and then see the architecture and also the cytological types, and you can differentiate from an infective and non-infective etiology. Then among the non-infective itself, whether it is an inflammatory or a neoplastic. And in neoplastic, it can be either a primary neoplastic or a secondary, as I mentioned. You can have metastatic carcinoma in the node that can be identified. And then if it is a primary neoplasm, it is a lymphoma. And to differentiate between a non-Hodgkin's and a Hodgkin's lymphoma also is possible. There you have the additional ancillary tests like the immunohistochemistry, which can be, that is a antigen in the cell is identified by a antibody to which a dye is attached. So depending on which cell is, which antigen or which IHC is positive in that particular cell, you can tell the lineage of the cell. To, for example, you can say it is a carcinoma or a squamous cell carcinoma or a lymphoma. All these can be done with this IHC ancillary test.
So if you're looking at the characteristic distinction factors between benign and malignant, can you just quickly?
Yeah, benign in a histopathology slide. Yeah, in benign, actually the main feature is a architecture of the node. As Madam described the node, you will be able to see the 3 different compartments separately. Even though there will be hyperplasia, depending on the antigenic stimulation, there will be only hyperplasia. So the entire node will retain its architecture. Whereas if it's a neoplastic, that cell is continuously proliferating. It won't be limited to its compartment. So that is called effacement of architecture. So you look at the architecture first, that pattern will be lost in the node. Then you look at the cell parameters like the cytoplasm, nucleus, etc. Depending on that, you can subclassify the neoplasm.
Thank you. Kiran, so from a physical examination perspective, what are the key things a student should remember while examining a lymph node?
So in this, in an evaluation of lymphadenopathy, history and general examination plays a very important part.
Right.
And it has to be systematic. So when we take the history, first thing is the name, the age. So if young people are coming to, if young females and all are coming with lymphadenopathy, there's always, we'll have to think of autoimmune causes,
Right.
SLE. So autoimmune aspect has to be looked into that. Then what occupation they are doing. Suppose the occupation related diseases, like if the patient is working in a farm or he is exposed to a lot of animals.
Right.
So diseases that can cause lymphadenopathy, like brucellosis, if they are exposed to milk and milk products. And like all occupational diseases have to be looked into. Another thing is where they're from also plays an important part. Certain diseases are endemic to certain places. So if a patient from Jharkhand comes or Bihar comes with fever and lymphadenopathy, leishmaniasis should be in your differential. So that is also important. History taking now, where the node is actually will also give you a certain amount of clue. Suppose they come with preauricular, postauricular, submental, submandibular. Usually these are seen in viral infections. Right. Anterior triangle and the anterior cervical, posterior cervical, usually head and neck infections, brucella, toxoplasma. Then you have your lymphomas, etc. Then your left supraclavicular lymph node. So then if they've come with a node like that, then we'll have to look into GI malignancies. Axillary node, again malignancies, breast malignancies, and other lymphomas, etc. we'll have to look out. Then inguinal region lymph nodes, if they're coming, then sexually transmitted diseases also will have to be ruled out. Epitrochlear nodes, again we'll have to rule out immunocompromised state. And then the node, what size it is, whether it is mobile, whether it is tender or not, all that is actually important. That is the present thing. And then we'll have to look into whether the patient is actually having systemic symptoms. That is whether it is a systemic disease which is actually causing this. Whether the patient has fever, night sweats, weight loss, etc. So whether tuberculosis or other malignancies or HIV have to be ruled out, has to be looked into. Next thing is whether the patient's past history, whether he is immunocompromised, whether he has diabetes, whether he's had tuberculosis or HIV in the past. Family history also plays a major role. CA breast, CAO, etc. Any malignancies which are running in the family. Then whether the patient is on any medication, that is also a very important thing. Like I said, medications, examples are allopurinol, carbamazepine, phenytoin, imatinib, etc. So these are all reversible causes of lymphadenopathy. Once you stop the inciting drug, the lymphadenopathy actually resolves. Another thing is his social activities, that is his alcohol intake, his diet, whether he takes uncooked meat. So there are certain diseases which actually come like that. And then his sexual activity, because STIs have to be ruled out. And these are from history. We should be able to get a differential, at least place them, whether it is infectious, whether it comes as autoimmune, whether it comes into the malignancy, or fungal also, histoplasma, coccidioidomycosis, etc. Right. And other diseases like your HLH or Kikuchi. So, and with general examination, we should be able to make a differential, which should help us to order our investigations and start treatment for it.
Thank you. George sir, from a surgical aspect, how will you proceed with an evaluation and management of lymphadenopathy? Yeah.
Looking at the patient, first thing is the patient should be fit for surgical procedure in the first place. So the patient is evaluated and found out whether the patient can undergo a surgical procedure for that matter. First thing is that the patient is requiring a fine needle aspiration cytology. It's nothing much, but we'll have to have a bleeding parameters done. That is PT, PTTK, or if the patient is on any anticoagulants, we'll have to wait till the anticoagulation is stopped and the effect is worn off. And once the patient is stabilized for a surgical procedure, it depends on the area on which you're going to operate, or the most prominent lymph node, or the most prominent area in which you require this lymph node to be taken out. So you can go for an excision biopsy if it is too large and you can access it very easily, or if it's very hugely humongous and you need a diagnosis for a complete management of that, you can go for a true cut biopsy from that, for that matter, so that you're not near any vital structures. But considering the fact that if you have a lymph node, usually you can go for an excision biopsy, and if you feel that there is infiltration to the adjacent structures, you can go for a wedge biopsy of that. You need not take out the complete lymph node, but a part of the lymph node can be taken, and then that can be sent, because nearer to the adjacent structures which are quite vital, if there is a nerve involvement. We are just looking at the diagnostic aspect of it. But if you're looking at a therapeutic aspect of it, as you would consider a ileoinguinal block dissection, or for that matter, retroperitoneal lymph nodal dissection, or for that matter, a modified radical neck dissection or a radical neck dissection, then of course we'll have to take out the complete group of lymph nodes which are involved. So that involves a certain amount of risk in sacrificing vital structures. The patients are well informed and informed consent is taken that these are the complications associated with these. So considering the fact where it is, how it is, and how we are going to tackle and for what purpose are we going to take it out, that has to be also confirmed and informed to the patient and the bystanders, and depending on the area in which it is present, if it can be taken out with a local anesthetic or it requires general anesthesia, depending on the depth of the node which is present, accessibility of the node. So all these factors contribute how you are going to intervene surgically. So the patient has to be seen as a whole rather than bits and pieces where you just take a decision for that matter.
Just to supplement that question, do you think any radiological imaging will help us kind of determining on how to plan the surgery?
Definitely, radiological imaging is one of the areas where you can rely upon, especially when you're planning a surgical procedure. Especially, you will have a large mass of lymph node. As Dr. Kiran had put it, that patient might be having tuberculosis. So, tubercular lymph nodes are usually matted; they all come together. So sometimes it might present as a huge group of lymph nodes, but there might be some caseation in that. So once caseation occurs, there might be liquid material, for that matter, cold abscess or pus in that. That pus might mimic as a huge lymph node. So in such cases, you can do a radiological imaging and find out whether there is any caseation undergoing, whether it's a collection underneath, or for that matter, if the patient has got a hematoma which is adjacent to that, we can pre-plan and we can determine. But if the node is relatively easily situated and it is not near any vital structure, rather it is better to go for a intervention straight away than wait for a radiological procedure.
Thank you, sir. To Dr. Akshara. Ma'am, can we discuss the anatomical basis for distinction between superficial and deep lymphatic drainage systems and provide some examples for each?
So lymphatic system, as I already mentioned, the main component are lymphatic vessels and the lymphoid organs. So lymphatic vessels can be classified drainage system into superficial lymphatics and deep lymphatics. So the lymphatics that drain the skin and the subcutaneous tissue, that is called as superficial lymphatic channels. And deep lymphatics are the channels that is deep to deep fascia. So that means the deep structures it is draining. So they are called as deep lymphatics. So, in the case of superficial lymphatics, we can consider some lymph node draining like superficial inguinal node. For example, we can take, it is along the superficial vein, and these superficial lymphatics usually will run along with the superficial veins. For example, this superficial inguinal lymph nodes, they are running along with the great saphenous vein. Like we are getting the deltopectoral lymph node, they are concerned with the cephalic vein, and supratrochlear lymph node, which are draining the medial aspect. So they are draining the medial aspect of the skin of your medial side of your forearm. And the superficial inguinal node, they are concerned with the skin of the external genitalia like scrotum, penis, and all these are drained by the and the lower part of your abdominal wall. That part also drained by the superficial inguinal lymph nodes and the channel. For deep lymphatic system, if you take this one, para-aortic nodes, that is on either side of the aorta, they are giving rise, their efferents channels is giving rise to this lumbar trunks. So this lumbar trunks is in turn draining to the cisterna chyli, and how this thoracic system is happening. So that is an example for the deep lymphatic system. Other one is an example for the superficial lymphatic system.
Right. Okay. To Kiran, what are the usual or relevant laboratory investigations which you usually do for the workup of lymphadenopathy?
Again, the clinician should have a set of differentials from a proper history taking, because the investigation would actually depend on that. But basically, we could divide them into one is your basic labs to see whether there is actually a systemic infection or not. Whether we get the infection, whether the cause is actually infectious or not. If the counts are on the higher side, ESR is on the higher side, then we usually suspect bacterial infections. a little bit of thrombocytopenia, again maybe a viral infection. Then secondary would be viral markers. If we feel that it is more in case of if the causative organism is a virus, we could send for viral markers, HIV, CMA, etc. We can do all the viral markers. And then the second step would be your imaging. Imaging, like everybody had said, ultrasound, CT, and PET also plays a big role. By doing an ultrasound, and like ma'am said, if the architecture is preserved, we can generally rule out malignancy from nodes. And if we are suspecting malignancy, PET scan also plays a big role, and it will also guide us on telling which node would have to be taken to get maximum yield. So depending on our differentials, we will have to look. If we are suspecting TB, we will have to take the node out. We will have to send for gene expert AFB culture. And the gold standard is always biopsy.
Okay, thank you. To George sir, can you explain this concept of sentinel node biopsy and what role it plays?
Yeah, that's a very good question. Actually, sentinel node biopsy is an evolving surgical procedure which has evolved down the line over the years. What do you mean by sentinel node biopsy? Sentinel meaning a sentry or a guard which guards the particular area. So when you consider a group of lymph nodes in an area, say you have a axillary group of lymph nodes draining the breast and the adjacent skin over that area, there is a node which drains that area first. All the lymphatics join together to come and drain into that particular lymph node. So in such a case, that lymph node is like a sentry. That's a lymph node which allows the lymphatics to come from the pathological part or from the tumor area to that particular group of lymph nodes which are spread all over. So if you consider the anterior axillary group, you consider lateral group, apical, central. So all these areas are given access to by the sentinel lymph node. So earlier days, if the patient had a clinically palpable lymph node and it was suspicious, say it was hard metastatic and you think that it is a metastatic node, and with an FNAC we can diagnose. Sometimes FNAC is not 100% a proof that there is a metastasis in that. So we are giving a certain amount of doubt whether we need to intervene and take out those nodal groups, because when you take out a complete set of group of nodes, there are complications associated with that. You can have either a hematoma there, or a lymphoma there, or a seroma there, or for that matter a long-term complication which is associated with is a lymphatic edema which happens in that particular draining lymph nodal group. So to overcome all these things, it's really absolutely essential to take out that lymph node region or that lymph node group. We will have to determine whether there is a metastasis at all. So majority of the times it might be just an inflammatory metastasis rather than a tumor metastasis. If it's an inflammatory metastasis, we can give antibiotics and wait for it to resolve, and then we can go ahead and do a tumor resection along with that lymph nodal dissection depending on the sentinel lymph nodal finding. So considering a sentinel lymph nodal finding, we can have a sentinel lymph node in the inguinal region, like the external genitalia, the penile shaft which is drained, especially the first node is called the lymph node of Cabana. When you come to the sentinel nodes of the axilla, you don't have a particular name for that, but there are areas where you can find there's a single node which is draining that. So considering that particular node which can be traced out, the most modern technique is to use radio tracer. Earlier days they used to use methylene blue dye, but now with the evolving standards and evolving methodology, usually radio tracer is the one which is used, and the commonly used radio tracers which are used are either it's technetium sulfur colloid, or you can have albumin nanocolloid, or you can have technetium antimony sulfide. So considering this, the particle size of these nanocolloids and colloids differ. The more the finer particles, the better penetration into the lymph nodes. So considering the chronology of the nodes I've told you, especially the most smallest particles are with antimony sulfide technetium. So it all depends whether it's available or not, but most commonly available is technetium sulfur colloid. So you either inject into that area of pathology, either it can be peritumoral or it can be intratumoral or it can be superficial depending on where the pathology is, and you wait for that radio tracer to go into. Usually it is done a little before surgery, and 5 to 30 megabecquerels of radio tracer is injected into that area. So this goes to the first lymph node, and a handheld gamma probe is held, and it is checked which node has the maximum radioactivity. And once you find that node can be taken off and sent for a frozen section study. And if that shows tumor in that, it's an indication that the whole area has to be removed. It doesn't show tumor in that, of course, you are pretty sure that you need not go for a quite morbid procedure which can prevent further complications. So that is how it goes.
Right, sir. Akshara ma'am, you did touch upon it in your initial answer, but can you explain the lymphatic drainage pathways of head and neck region, and also how does this knowledge inform the evaluation of lymphadenopathy in that area?
Head and neck region, as I already mentioned, there are 3 groups of lymph node, like superficial, deep, and we can consider the deepest group of lymph nodes there. And which channel is draining it? It is the jugular trunk. We have right jugular trunk and we have the left jugular trunk. And this right jugular trunk and this right bronchomediastinal trunk and the right subclavian trunk, they will unite and form the right lymphatic duct. And this right lymphatic duct will open to right venous angle, that is between the right internal jugular vein and the right subclavian vein, or any of the veins. Usually it is there. Like that, left side we have the left jugular trunk. The efference of this deep cervical node is giving rise to this jugular trunk. So this jugular trunk on the left side will drain into the thoracic duct. So thoracic duct is also will open into the junction between the left internal jugular vein and the left subclavian vein. That is a venous angle there. So the deep cervical nodes as efferents are forming this jugular trunk. That is the thing. So what are the lymph node there? I mentioned a superficial group, deep group and deepest group. And superficial group which are include the buccal node, mandibular node, that is the parotid nodes are called pre-auricular node, and the mastoid nodes are called as post-auricular nodes, draining the posterior aspect of your scalp. Like that, we have the deep group. In that deep group, we are getting the submental node, submandibular node. So submental node is draining the tip of your tongue, the floor of your mouth, the gums of your teeth, the incisor teeth, that gum, it is draining it. So if we are having the swelling of that part of the node, adenopathy of this node, we can guess the infections of that part of your mouth. Like that submandibular node, it is draining this rest of the like anterior part of your cheek, the center of your forehead, and the anterior two-thirds of the tongue. All these areas, upper lip entirely, and lower lip except the central area, all these areas are drained by the submandibular node. So if there is enlargement of the submandibular node, we have to expect some infection of the related areas that draining, so that enlargement will be there. And the other group I mentioned along with internal jugular vein is upper lateral group. That is most important among this is jugulo-digastric node below the posterior belly of digastric muscle. We can identify that, and that is the primary lymphatic drainage of the tonsil. So you have acute tonsillitis, there will be enlargement of this node, we can find out. Similarly, in the lower lateral area, we are getting the jugulo-omohyoid node. That is the principal node of your tongue. So again, if there is enlargement, we are suspecting that it is affecting the infections. And although the cervical nodes are also involved in the tuberculosis, so submandibular nodes also, tubercular bacteria can infect the submandibular nodes. So these are the important and deepest nodes. They are the important nodes. In addition to that, in the posterior triangle, we are coming across the supraclavicular nodes. That is the Virchow's nodes, and we already heard that Troyer's sign. So there is enlargement of this node. We have to. This is the metastasis area from the GIT as well as from the testis, or we have to suspect there. So if there is enlargement is there, then we have to look for that. So this is another another adenopathy we can see in the head and neck region. So these are the lymph nodes there. So finally these are draining in the left side to the thoracic duct and on the right side to the right lymphatic duct. So the final aim of the lymph is back to the bloodstream. So the lymph is back to the bloodstream through this and entering the venous system.
Thank you, ma'am. To Indu madam, ma'am, can we discuss the different types of lymphoma based upon the cell lineage and their characteristic histological features, and also if you can explain the concept of staging in lymphomas?
Yes. So lymphoma is a primary neoplasm of the lymph node, and it can be broadly classified into Hodgkin's lymphoma and non-Hodgkin's lymphoma. So Hodgkin's, the main difference between these two is that Hodgkin's is, though it is supposed to be derived from the B lymphoid cells, they will lose all the markers of the B cell during the process of neoplasm. And whereas the non-Hodgkin's lymphoma, they can be further categorized into B cell lymphomas and T cell lymphomas. So according to the latest WHO classification, you have more than 30 types of lymphomas. So if I discuss that in detail, it will be difficult. So I can just touch upon the important ones, especially the Hodgkin's lymphoma. So Hodgkin's lymphoma is usually seen in younger age group, and the two important features of this lymphoma is that one is that the neoplastic cells are very less in number. Usually 5 to 10% of the lymph node tissue will only show the neoplastic cells, which are classically called the Reed-Sternberg cells, and the majority of the tissue will be occupied by the background cells, that is the inflammatory cells, which will come and surround this neoplastic cells because of the cytokines which are released by these Hodgkin cells. And so that is one important feature, and the importance or relevance of this is that in an FNAC or in a true cut biopsy, as Sir mentioned, you tend to miss these cells. Okay, you will get only the background cells, not the neoplastic cells. So that can be mislabeled, and that there can be a delay in diagnosis. So in such cases, it is better that you do a whole node dissection for diagnosis. Then Hodgkin's lymphoma itself can be classified further into a nodular lymphocyte predominant Hodgkin's lymphoma and a classical Hodgkin's lymphoma, which has 4 subtypes: the nodular sclerosis, the mixed cellularity, the lymphocyte rich, and the lymphocyte depleted. And then in non-Hodgkin's lymphoma, you have the B cell lymphomas and the T cell lymphomas. And according to the differentiation, it can be further divided into a lymphoblastic lymphoma, which is the counterpart of the leukemia, the T leukemia or a B leukemia. It is B lymphoblastic and T lymphoblastic lymphomas. Then you have the mature cells. So according to the different compartments and the different cells constituting these compartments. For example, a follicle, a lymphoid follicle, there is a germinal center, there is a mantle zone, and there is a marginal zone in some. So the B lymphomas, if you see, are derived from or differentiate to these cells. Within the follicular center, you have the centrocyte and the centroblast. So you have a follicular lymphoma arising from that. Then you have a mantle cell lymphoma, that is differentiating towards the mantle cells of the node. Then a marginal zone lymphoma, that again is differentiating towards the marginal cells. Then you have a diffuse large B cell lymphoma, which is an aggressive lymphoma. Similarly, in T lymphomas also, you have a lymphoblastic lymphoma, which is the most immature one. And then there are peripheral T cell lymphomas, which are more differentiated, that include peripheral T cell lymphoma, angioimmunoblastic lymphoma, etc. So that's a broad classification of the lymphomas.
Thank you, ma'am. To Kiran. Kiran, can you just share with us what is the usual management strategies you follow for the most common causes of lymphadenopathy? Sorry.
Staging of the lymphoma, to put it simply in simple words, a stage 1 will have a single group of lymph nodes. A stage 2 can have 2 or more on the same side of the diaphragm. Right. A stage 3, you have lymph nodes involved on both sides of diaphragm. And stage 4, you have an extra lymphatic site also involved, like the bone marrow or other sites.
Right. To Kiran, so basically, can you share with us what are the usual management strategies you follow for the common causes of lymphadenopathy you see?
So definitely the causative organism has to be identified and treatment depends upon that. So usual bacterial infections, we start them on antibacterials. Most commonly what we see, one infection is tuberculosis, so that requires ATT. Usually lymph node tuberculosis treatment is actually ATT for up to 9 months. Then we have usual viral causes are usually self-limiting, but if it is HIV, the patient will actually have to be on ART, only then it would actually come down. Fungal causes will also require antifungals. So these are the infective causes which will require antibiotics. And if it is autoimmune, then the patient might require immunotherapy and steroids for it. And malignancy would be a combination of surgery, radiotherapy, chemotherapy, depending on the site and type of organism.
Okay. Last question to George sir. Sir, you did tell about certain complications which you see with lymph node dissection. So, what are the usual complications? Is there any techniques to kind of minimize the complications?
All depends on the area you're operating upon. One of the things which mostly complicates lymph node dissection, especially when you have a large group of block dissection being done, is the lymphatic channels open up and then it forms a lymphoid collection which leads to collection once the patient goes and then comes back, and sometimes it's so disgusting that it keeps on pouring out like water. That's called lymphoria. So especially in conditions like ilioinguinal block dissection, or you have an inguinal node or a set of nodes removed from the inguinal region, that's very, very common, especially in the inguinal region. Considering complications which are there in the axillary part, you can have the same thing which happens in the inguinal region also, but you can also have areas where you have damage to the adjacent structures, especially the axillary nerve, the axillary vein, or for that matter the axillary artery. And depends on the way you tackle these areas, you can have a hematoma or you can have a seroma, and damage to the vital structures will lead to loss of function of that particular dermatome, or loss of sensation in the dermatome and loss of function to that particular muscle also. If you're dissecting in the axilla and say you've damaged the thoracodorsal nerve, you can have problems with latissimus dorsi. So there is a lot of complications associated in the operation you're doing, but it all depends on the amount of lymph nodal dissection you want to do. That's why sentinel lymph node mapping is an important thing, where you prevent all these complications. If you want to take out just a berry picking, you can take out the involved lymph nodes and prevent all these complications, or you can just take out one lymph node and find out there's nothing much to be done and it is not positive for malignancy. You can sort of give away with an axillary dissection, or if there is extensive disease, anyway you'll have to go for that. But all these can be dealt with depending on the surgical experience and the prior studying of that particular area by imaging, or for that matter how that patient is going to behave with this operation, whether the patient would be able to take such a surgical trauma, or there are other modalities which can be treated by doing a diagnostic lymph node biopsy and then doing away with the axillary dissection or an ilioinguinal block dissection, or for that matter retroperitoneal dissection, whichever the area the lymph node is situated.
Thank you, sir. With that, we have come to an end of the pre-planned questions. Just a last round. So what are the common questions a UG student can expect from this topic? If we have missed on anything, please feel free to elaborate on that. We'll start with Kiran.
For the exam, definitely how the approach is actually very important. What all things to ask, how do we classify whether the symptoms all fit into whether it is infectious or not, autoimmune, malignancy, or whether it is so the approach to lymphadenopathy is also important. And physical examination, that is also very important. For your examination, they might even ask you how to examine the lymphoid system. So that also has to be studied in detail.
Practical, I think?
Practically how to examine. It is important.
Right. Sure.
So from the anatomical point of view, the questions usually asked, actually the lymph nodes of head and neck is very important. And this one supraclavicular nodes, because of this Virchow's nodes, questions are coming. And structure of lymph node, histology of the structure of lymph node is important as well as for the theory, as well as for the practical sections. So each sections and how it functions, all these things are very important to draw also.
Okay.
Draw also, they should be aware of that.
Okay.
And in addition to that, each region lymph nodes are teaching a lymphatic drainage of upper limb, lower limb and head and neck usually will be there. So these are some of the important questions, and from the knowledge perspective, they have to know what is the primary lymphoid organ, and what is a secondary lymphoid organ. That because primary lymphoid organ is the area where there is production, differentiation, maturation is happening there, and they are the bone and the thymus. So bone is hematopoietic cells, and thymus is where these precursors are given rise to T cells. So and this is coming to the bloodstream. So they should know what is primary, what is that, and then they have to know the other important is lymphatic vessels, and they unite the small lymphatic vessels. They starting as lymph capillary, and they're uniting for the small lymphatic vessels, and finally they are giving rise to the large lymphatic trunk. That is the most important one is thoracic duct, and other one is right lymphatic. Thoracic duct is another short note question usually asked. So it is starting as a cisterna chyli in front of the lumbar vertebra, and it received the lymphatic from left side except the right half of the trunk or the right side of head and neck and the right upper limb. Except that most of the and superior surface of liver, all other areas are drained by this thoracic duct. And thoracic duct, it received this from the abdomen, the intestinal trunks, it received the lumbar trunks, it received all the other trunks are coming to the left bronchomediastinal trunk. All these things are draining to the thoracic duct. So thoracic duct, as a short note, they have to prepare what are the tributaries of it, where it drains, they should know these components. Okay.
Into ma'am?
Yeah, from pathology, actually, most of the hematopathology questions come from blood, then the leukemias like that. From lymph node, only a few questions. One is in the non-neoplastic IMN, infectious mononucleosis. You can get as a CPC or as a short note. Then among the neoplasms, two important questions. One is a Hodgkin's lymphoma, the classification and the morphology, the slide also they need to know. And another one is a Burkitt's lymphoma, which you can get as a short note.
Okay. Yes, sir.
Lymphatic drainage of breast, very very important as a short
also,
question.
yeah.
And
Amongst the surgery question, most of it has to be tackled clinically. Basically, most of it is clinical science which is asked in surgical questions. So considering the theory part, because we have the CBME mode of education going on, the competency is what we're assessing. So majority of the questions are extrapolated as problem-based questions into the theory. So they'll be given a clinical case scenario where a patient comes with fever for so many days, night sweats for so many days, and on examination there are cervical nodes and other inguinal nodes. So what would your probable diagnosis be? So the student has to practically know how he is going to answer such a problem-based question. So if he knows about lymphoma, he can tell that yes, this is a lymphoma which needs an answer in this subsections as it is asked for. But first of all, he should know when there is a characteristic mentioned in the question, he or she should know that what are the characteristics for a diagnosis of a lymphoma node. So technically speaking, the consistency matters for that matter. So the practical aspect where the student has to learn is whenever one is examining a lymph node or a lymph nodal region, it has to be under various subsections. One is the site, second is the size, third is the number, fourth is the mobility, fifth is the consistency, sixth is adherence to the adjacent structures, and depending on the special characteristic of that node, especially diseases like tuberculosis, there will be matting of lymph nodes. So the student should differentiate what is matting from a conglomerate mass of lymph nodes which are not matted. So that is where the student extrapolates the practical knowledge into theoretical base. So when you consider about surgery, medicine, gynae, pediatrics, this is where the difference lies. And then all this can be extrapolated as a MCQ. For that matter, there will be a lymph question which will be asked, what would be the consistency of a syphilitic lymph node? It can be shorty, or if there is a papillary carcinoma metastasis, it can be a hard node, or that matter squamous cell carcinoma, hard node. So all these things would extrapolate on how he or she is going to answer the question theoretically, and the same would evolve into the practical aspect of it when he or she comes to examine a patient. So both has to be sort of mixed together, and student has to prepare well in advance, because what we are looking at is the competency of the student rather than just thinking about a practical or a theoretical aspect of it.
Thanks a lot. With that, we come to the end of the session. Thank you all for such a wonderful discussion. Thank you.